but we're going to start the session, and I'd like to welcome Dr. Cullen, who's an ophthalmologist who works here in Sandton. I'm close to Sandton. And she's going to do a brief presentation about eye health. And then we're going to open up the chat to everybody so that you can ask your questions or pop them in the chat box so that either Kath or I can ask them. I'd like to just point out that Kath is also in the room over here. A lot of you know her. Kath, would you like to say anything?
Oh, no, I'm actually here as a parent as well. I'm here to learn. I had lots of questions about uveitis over time, so I'm here as a JIA mum, but it's very nice to see you all. Hi.
Okay, great. Thanks, Kath. And then can I ask you, please, if you would kindly keep your cameras on. As a presenter, it really helps a lot to talk to people on Zoom, but also, you know, we're a community and it's really nice to kind of be together, although it's not face to face, you know, physically, it's really nice to, you know, just know that there are other people out there who have similar battles and struggles, because this can feel pretty lonely. And if you have also any questions or any comments, you all have my WhatsApp details. You're welcome to send me a WhatsApp. I'll check it from time to time. But otherwise, you are welcome to use the chat box. And then also, may I ask you to please put your devices on mute so that we can, my daughter's walking in, so that we can hear everybody. And if you have a question, to put up your hand or to just hop on after the presentation. There is a little at the bottom of your screen, or if you're on your device, you can have a look on your phone. There's a little icon that says reactions, and you are welcome to use those reactions anytime, especially if you have a question to ask. Is there anything else? Or put up your hand like Kath.
Laura, I just wanted to say I don't see the normal chat box underneath. Is that perhaps a setting that was excluded? Because I'm not quite sure. I don't, like, for example, I'm looking and I'm not sure where I would actually type a comment or a question. Oh, hold on, it's in more. Okay, don't worry, I found it.
Okay, sorry, I use this room all the time, so it should be there somewhere. So you might have
it's under, if the rest of you are battling, it's under the little 3 dots more to the right, and then I found it.
Yeah, if you have, also if you're on a smaller device, then it's sometimes is somewhere else, and I'm afraid I can't help you there. Okay, is there anything else before we begin? Okay, thank you. Dr. Cullen, it's over to you. Will you tell us a little bit about yourself before you begin?
Okay, well, thanks for inviting me, Laura Ann, and thanks for everyone for joining. So, as you all know, I'm an ophthalmologist, and I've super specialized. Well, I've done a fellowship in pediatric ophthalmology and adult strabismus. So my practice is geared mainly towards kids. We do adult strabismus, which is adult squints, once a month, but otherwise the rest of the time we're seeing kids. I studied at Wits. I then did my ophthalmology specialization, and then I went over to Australia and Canada to do to super specialize in pediatric ophthalmology. So that's a bit about my background. Yeah, so that's about it. So my talk this evening it's going to be really short and quite informal. So looking forward to questions, and I will answer them to the best of my ability. So I'm going to start sharing my screen, if that's right. Is everyone seeing that? Yeah, great. Okay. Okay, so we've covered this. That's a little bit about me. Okay, so uveitis, as you probably all know, are very not commonly associated with JIA, but there is a higher risk of getting uveitis when a child is diagnosed with JIA. And uveitis, by definition, is really an inflammation of the uveal tract. So here's an anatomical drawing of the eye, with the cornea being the glass dome of the front of the eye, and the red highlighted areas being your uveal tract. So part of that is your iris, or the colored part of the eye, the ciliary body, which is the part of the eye that actually makes you focus for distance and near, and then the choroid, which is the layer underneath the retina, or the back of the eye. And depending on where the inflammation occurs, we then divide it, or we subclassify it into anterior, being the front, intermediate, being the area just behind the lens there, and then posterior uveitis, being mainly the retina. You can get inflammation of sort of the whole way through, and that we call a panuveitis. So the exact mechanisms, the exact mechanisms are really not fully understood. We don't know the exact mechanism behind uveitis in juvenile arthritis. We know it's immune modulated, where the immune system mistakenly starts attacking its own body, and it starts attacking the uveal tissue. That's basically it in a nutshell. In the context of JIA, the autoimmune system, we know that there is a predisposition for the body to attack certain organs, but it's interesting that not all kids with JIA will get uveitis. So we don't understand the exact mechanism of what's behind it. We know that there are certain risk factors or higher risk factors. For example, kiddies with a positive ANA, they're at higher risk. And also the younger kiddies are more at risk than if they develop juvenile arthritis at, say, an older age. So it's an interesting condition because in a lot of cases of adult uveitis, the patient will present with like a painful red eye. And that is so not the case with kids. It's kind of a silent disease. And most of them will present, unless they're sent for screening, will present with complications such as cataracts or glaucoma. So as in the slide, I've said, most of the kids are asymptomatic, and it's only through the screening process that it's actually picked up. In rare situations, they'll present with a painful red eye, light sensitivity. So when they go outside, it's quite bright, blurred vision, cataract. So that's when the lens becomes white or opaque. Glaucoma, which is high pressure in the eye. And unfortunately, vision loss kids still present with vision loss today. So here's some pictures of kind of the complications that we see kids presenting with. So at the top left, I don't know if you can see my mouse or the arrow. Are you able to see that? Yep, okay. So this is band keratopathy, okay, and that's affecting the front glass part of the eye. Over here, you've got the lens, okay, that has become opacified into a cataract, and there's some adhesions of the iris to the actual lens. Over here, you've got images of the back of the eye. And if you compare this little nerve here to that little nerve there, you can see there's swelling or blurriness of this nerve. And that's a complication of uveitis as well, and that we get swelling or of the optic nerve. In this picture, you can see a little tube, okay, coming, I don't know if you can see because I've got these, sorry. Let me see if I can, there we go. You can see the little tube, and that's sometimes how glaucoma is managed. So glaucoma is a condition that the pressure in the eye becomes elevated, and this causes optic nerve damage. This is very seldomly how kids present with this painful red eye, but it is possible. Okay, and up here at the top, we've got the back of the eye with swelling in it, okay, or macular edema. So those are some of the complications of how kids can present. Okay, so when we're looking for signs of uveitis, we grade it according to how many inflammatory cells they are, and basically you have to detect it at very high magnification through the slit lamp. And really, what you're looking for is, you know, if you see like a sunbeam come through a dark room, and you see those like speckles of dust floating, they're like shiny. That's kind of what we're looking at. So these very tiny pinpoint little cells are floating about, and depending on the number in the anterior chamber, which is again the area between the cornea and the iris, or sometimes in the vitreous as well, which is further back, we quantify it, we grade it. Okay, so minimal cells would be 0.5 plus inflammation, and then all the way up to greater than 50 cells, which would be 4 plus. We also look at what's called the flare, so it's a kind of a smoky appearance, and that's also an indication that there's swelling or inflammation within the eye. So my colleague, Professor Chris Tinley, did a really nice, interesting study at Red Cross. And what they did is they looked at all the pediatric patients who presented to the eye clinic in Cape Town with non-infectious uveitis, and they studied this. It was a retrospective study, so they looked at case charts in history, and they reviewed the disease characteristics and the outcomes on immunomodulating treatment. And what they found was 55% of these kids presented with complications at their first visit. And that's really sad, because, you know, for me personally, you know, 90% of your sensory input, so your hearing, between your hearing, sight, taste, smell, that comes from your vision. So it's very, as you can appreciate, dear to my heart. 48% were due to juvenile idiopathic arthritis, mainly oligoarthritis, younger kids and ANA positive. 41%, they couldn't find a cause. Okay, it was often both eyes involved, and all of these kids presented with cataracts. And then a fewer percentage presented with the likes of sarcoid and Behçet's. Okay. So management really involves a multidisciplinary approach. And here's where we work very carefully with rheumatologists. So I deal with the eye, and I'm very happy to do eye treatment. But when it comes to anything systemic or where the body's involved, I think you owe it to the child and the parents, the family, in the best interest of the child, to get other specialists involved. So from an eye point of view, if the uveitis is localized to the front part of the eye, it often responds well to steroid eye drops. Okay, the further back it gets more and more difficult for those eye drops to penetrate that far back. Some localized treatments we can use are steroid injections into the back of the eye and also onto the floor, the bony floor of the eye. A lot of the times, we worry about side effects of steroids, and we know that about 1 in 3 patients will be what we call steroid responders, where they will get a rise in pressure, glaucoma, which can, if they have that pressure for a prolonged period, it can cause optic nerve damage and vision loss. So that's something that needs to be monitored quite carefully. So we don't want patients on long-term high-dose steroids. And that is where, the the systemic medications come into play, whether it be starting off with steroid treatment and then moving on to drug modifying agents, and if not controlled, going on to biologics. So when it comes to screening, we have guidelines, okay? And the screening intervals are based on several factors, namely the age of the child, the ANA result, and the classification of the uveitis. So is it oligo? Is it a single joint, et cetera, et cetera. So we're guided by the rheumatologist on that. Your screening intervals range from every 3 months to once a year. So really, in conclusion, I think one of the most important things is the screening process, because unless kids are brought in, they really don't complain of problems with their eyes. As they get a bit older, they can start recognizing the signs. And I've got a few kids who we've extended the interval that we're seeing them, and they've come back sooner because something's happened. Sometimes when we stop the biologic, I've had a patient who the biologic, she was doing great for a few years, and then she realized she was seeing things again in her eyes, and she knew that was a flare-up. So that's kind of where we head to as they get a bit older. It can sometimes be a tricky diagnosis because obviously, you're needing a very high magnification, sort of 25 to 40, to see tiny specks. And that's often quite difficult with a child who's scared. They've been through a lot with their condition. And also, small kids don't like to stay still. So it can be a challenging diagnosis to make. And a lot of the time, especially with my first examination of these children, you try and make it fun. And I always say the child determines what you get. So if there's no other concerning factors, obviously if you're picking something up, we would do an examination under anesthetic if we were really worried. But if it's just like a routine screening, you build up a relationship with the child and you make it fun. So they know that, when they come the next time, it's not painful. We're just taking a look, we're playing games. And I think that's so important with kids. It really is, just to build up that relationship. And another important thing is the communication between ophthalmologist and rheumatologist, as well as parents. So in a nutshell, that is my talk. So I'm going to open up the floor for questions. Really, looking forward to them if anyone has, and if no one has, that's fine as well. We can get an early night. One hand, Catherine?
Kath would like to ask something, but can I ask you to stop your
sharing?
Please? Thanks.
Absolutely. There we go.
Okay, great. Thank you. Yes, Kath, and then, if anyone else is, you just hop in after Kath, no problem.
Claire, that was such a great talk. Thank you so much. My daughter was diagnosed many years ago, and I've never had such a comprehensive, clear overview of uveitis and what it is and how it's screened, and that was fantastic. So thank you so much for doing this.
You're very welcome.
You mentioned there's a greater incidence in children with ANA positivity. Just by show of hands with the rest of you, are you all comfortable with what ANA means? Just raise your hands if you don't know what ANA is, so I can just see. Okay, so ANA is autoantibody. So initially when your child was diagnosed, the rheumatologist would have done some tests, and they're looking for a couple of things. Usually they're looking for HLA-B27, which is a genetic modification that means that you have the potential to develop inflammatory diseases like arthritis. So that's one of the tests your child's doctor would have done. And another one they would have done is ANA. And ANA stands for autoantibody. So much like your body produces antibodies against, for example, the chickenpox virus, which we've just had run through our house in the last 2 weeks, your body produces antibodies to chickenpox. An autoantibody, auto means self. So an autoantibody is an antibody against yourself. and your it's a test that typically is only done once. They don't typically tend to repeat it, but ANA positivity just is one of the clues that your child's doctor is going to use to understand what subtype of juvenile arthritis they have and which complications they might develop. Dr. Cullen, was that a good, that's a good, I've done a good job.
Excellent.
Okay.
Yeah.
So I just wanted to ask you, you mentioned ANA, but not HLA-B27. Is there any relationship between those two things and or uveitis and HLA?
Sort of my answer would be I actually don't know. When it comes to the screening guidelines, it's really, I mean, we've got the tables. The majority of time it's to do with age, number of joints involved, and ANA. And it seems to be the more joints, the younger the child, ANA positive, the more frequent the ophthalmic visits are.
Okay. It's interesting because I know that, for example, in adults, so a lot of the subtypes of juvenile arthritis in children, in adults are recategorized or categorized differently, and they're categorized under a term called axial spondyloarthritis. And then that's where the gene HLA-B27 it also comes up a lot. And I know that in rheumatoid arthritis, for example, uveitis is not a complication. Or I think that's correct. Is that correct? So with rheumatoid arthritis, seropositive rheumatoid arthritis in children and in adults, I don't think uveitis is the same. There's not the same risk. Is that correct?
I'm not sure, to be honest with you. I haven't dealt with adults in quite a while, to be honest with you, besides that they've got a squint. It's something we test for in adults when it comes to inflammatory conditions. So I think there must be a relation between arthritis and uveitis, but other than that, yeah, I can't remember much, to be honest with you.
Okay. No, that's fine. That's no problem.
Sorry.
I wondered. No problem at all. No, I wondered about that. My daughter she's been screened twice a year since she was diagnosed 13 years ago, but she's always been completely clear. But recently, at the beginning of this year, she was great. She, for the first time, had a high, one of the pressure test was high. We went back a month later, It was normal. I didn't understand that was potentially an early symptom or a symptom of uveitis. I understand now why they asked me to come back. So my question is, should I stay on top of that a little bit more for the next couple of months, or is it fine if we've tested it twice?
You know what? Pressure in the eye, especially in kids, it can be, if you hold your breath, it can elevate. If you're tense, it can elevate. If you are sort of pulling away and blinking, it can elevate. We have a diurnal fluctuation in our pressure. So, you know what, if it was a once, depending on how sort of anxious she was, if it was elevated, I probably wouldn't be too worried about it. The fact that it's come down, it could have just been, and tell me, was it a puff test, an air puff? Yeah, that's not okay. So I'm less worried about that than an actual sort of reading with a tonometer. Yeah, because often as not, we often get it. Kids, you know, will pull away, they'll blink, and we get high pressure with an air puff. If it was consistently elevated, then I would say, you know, I'm a little bit more worried.
Okay.
I'd probably have it checked once a year. Yeah, or she'll have it checked at her ophthalmic visits.
Okay. All right, perfect. One last comment, not a question, but just to say we've been working very hard with Discovery to recreate the treatment baskets for juvenile arthritis and to make sure that it includes, as part of the treatment basket, screening with an ophthalmologist in accordance with the complication risk. So children that need to be screened twice a year or 3 times a year to make sure that those visits are covered as part of the standard treatment basket. And we've been working on it for a year. It's a slow process. They assure me that the treatment basket is actually confirmed, but it's not yet in the system. Apparently that takes some time. But for anybody wondering about whether ophthalmology is covered, we'll start with Discovery and then we'll move on to other medical schemes. But it's a absolute disaster that ophthalmology is not included as a standard service available to children who are at risk of this complication. So we're working hard on that.
Oh, well done on that.
That's it from me. I'm gonna stop talking now and give somebody else a chance to ask a question. Thank you.
Thank you very much.
Thanks, Kath, and that sounds really amazing. Yes, so I've got you down as Christian, but would you kindly introduce yourself and tell us?
Actually, Cynthia.
Okay, so you are Cynthia. Hi, Cynthia.
Yeah, Cynthia
How are
Stewart.
you?
How are you all?
Good.
Thank you.
Tell us.
So
Sorry, could you tell us about your child, their age, and their diagnosis?
Yes.
And then ask your question. Thank you.
Okay, so Scarlett is 10. She was diagnosed last year with juvenile arthritis. She has complicated by MAS as well. So she is on Actemra biological, and she's on methotrexate as well. She did have a flare about 2 weeks ago. She was in hospital. In the middle of this year, I noticed that she's been getting a lot of stars on her eyes. So one will pop up, disappear, and then the next eye will start, and so they go on just popping.
Sorry.
Unfortunately,
Cynthia,
when she was in hospital, yes.
your line is a little bit dotty. Could you turn your camera off and then ask your question, or carry on?
Okay, sure.
Turn your camera off so that we get just some continuity to be able to understand the context and the question better. Thank you.
Okay, sure. No problem.
Okay, Cynthia, can you go for it?
Is that busy?
Let's try. Let's go for it.
Okay. Okay, should I start from the beginning?
No, not necessary. Just from where you ended off. Yeah, thank you.
Okay, so she's been getting a lot of stars that come on her eyes. One would go away, another one appears on both eyes. And it's a constant thing. When she was in hospital now, unfortunately, they said she had COVID, so she couldn't see an eye specialist to take a look at her eyes. Is that something that affects anyone else, having stars all the time?
No, we've not had any experience of that, Cynthia. Is that okay? Would that be considered a complication?
Not really. We know some kids are more prone to stars or chalazions than other kids. And we know that when a child's immune system goes down, so if they're stressed, I often find it when kids are writing exams, they'll pop up. So if Scarlett's prone to them, it doesn't surprise me that there's a recurrence of them with her having COVID and having the JIA. So I often prescribe lid wipes, lid hygiene, ointments, and the best thing you can do for them is hot compresses. So a nice warm face cloth. I describe to my patients as almost like a pimple that needs to come out. Those little glands get blocked. And it's like the deep-seated pimples. So hot compresses, either with a face cloth, or I often ask my patients, boil eggs in the morning, keep the shell on and so you can hold the egg there the longest, okay? With the price of eggs these days, I don't know if you want to do that, but and then definitely I'd see an ophthalmologist, to see an eye care professional, just, make sure there's nothing else going on there. And then, get probably some ointments. And if she needs, sometimes we have to put kids on sort of a 3-month course of antibiotics, just to get to regulate the natural bacteria on their eyelids. But definitely start with the hot compresses, and you can get like an eyelid wipe from Dischem or Clicks. It's called Sustain Lid Wipes. It's like a baby wipe but for the lids, or the likes of Navi Blef. It's a eyelash foam cleanser. You can get it on Takealot or Dischem. If you do get it, get the blue one. Don't get the red one. The red one's a bit harsh. But that's kind of what I advise my patients. But in terms of its association with JIA, I haven't seen it directly related, but it was possibly related to her immune system dropping. Okay, and the stress she's experiencing or her body's experiencing. That's possibly where the flare-ups are coming from.
Or a consequence of the treatments as well. I think so Cynthia, are you still using biologics?
Yes, we are still on the biologic, yes.
Maybe a consequence of that as well. So probably definitely worth reporting back to the rheumatologist in case is she getting other infections a lot as well?
Yeah, she gets a lot of sores on her nose and stuff as well. She was on Zinplex, but the doctor, our rheumatologist, said that she could only take it for 7 days, and not for a longer period than that. So yeah.
I'm sorry you've had even more issues. I'm so sorry to hear that. But maybe a consequence of the immune suppression. So maybe just a general low immunity, and that's how it's manifesting.
Yeah, I think so as well. Yeah. Okay, thank you so much for your answer. It helps a lot. Thank you.
Thanks very much, Cynthia. Candice, I see that you're off mute, and I know that you have a couple of questions. Would you like to come on? Candice? Okay, I'm going to mute Candice. Would anyone else like to ask any questions? Yes, Karen.
Karen, you're on mute.
If you're on your phone, you need to swipe. Just keep doing some swiping and you'll find the off mute button. Or maybe touch the screen and the off mute button might appear at the bottom. Any luck?
That's a good idea, bringing the kids.
Yes.
Hi. Sorry.
There we go.
Technology savvy.
Yes.
Hi everyone. I've got 2 sons. One's this young one's we've just found out he's got the HLA-V27 gene. And then the older one, he has JIA and vasculitis. But he's always had terrible eyes, and he saw an ophthalmic surgeon, I'd say the middle of the year, and he said to us that Hayden is at risk of retina detachment. So I just wanted to find out, is that due to the arthritis, or is that what would cause that?
So my question is has the inflammation, has he ever had inflammation in the eye?
No.
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 Okay. Is he short-sighted?
Yeah, he has terrible sight. He can only see 40% out of the one eye and 60% out of the other, but he's like short-sighted, far-sighted, like the worst type of eyes.
And does he wear thick glasses?
Yes, we do have them specially made.
Thin down?
Yes.
Yeah.
Yes.
So it's possible that because if he's short-sighted, he's got a very long eye. And we do know that people with long eyes are more at risk for retinal detachments.
Okay.
It's rare because the jelly at the back of the eye is pretty formed. But as we get older, that jelly turns into a bit of a marmalade and it softens out. So it's, again, regular screenings and regular retinal checks. Okay. Yeah. And so that if they do find a hole or a tear, they can do something about it. They can laser.
Yeah, he did say Hayden ever sees, I think it's flashing lights or.
Yes, correct.
you have to get him to, you know, a specialist.
Yeah, you don't wait, you get him there ASAP.
Okay,
Yeah.
and would you check him once a year, twice a year?
Once a year is normally that's kind of the standard. Yeah,
Okay.
for retinal checks for short-sightedness.
Okay, perfect.
Yeah. And then it's kind of just to be sort of sensible. I mean, sort of, they say no contact sports, okay? But again, a child's going to be a child. Avoid trampolines, okay?
Yes.
Those kind of things.
Okay, perfect.
Good.
Thanks, Karen.
Thank you.
Thank you. Anyone else? Any other questions? I see there's a chat in the chat. Okay, Candace. Okay, so Candace said that she, her whole family isn't so well, and she possibly wasn't going to come on, but she's here, so that's great. Thanks very much. The question was answered through the presentation, and she says thank you. So thanks for being here, Candace. Are there any other questions, comments? Yes, Kath.
I have one more, sorry. I was wondering if uveitis, like juvenile arthritis, comes and goes in flares. Is it something that goes into remission and then it's gone, or can it come back at any time, much like arthritis?
It can unfortunately come back. I've had a child, she was beautifully controlled on her biologic, her Humira, and we got the uveitis under control, and she was on Humira for several years, and then we tapered it, and she was off it for several years, a good 4 years, and then a relapse. So yeah, it's one of those puzzling conditions. Yeah, and I think a lot of the time, you know, several patients, it can be so frustrating for parents as well, because it's not something you can see unless you're seeing with a slit lamp. So you're getting told by someone, you know, there's inflammation in the eye, and the child's got to go on these treatments, and you know, those treatments have side effects as well. And yeah, I think for a lot of parents, it's frustrating.
I think that's true. I know in our parent support group, the parents that have battled with uveitis say it is incredibly hard. And I think also hard because in many cases, if I'm not mistaken, like the cortisone drops have to be applied multiple times a day rather than just like once in the morning. And so it's actually quite an onerous regime as well. It's hard to keep up with, and it's hard to remember, and it's top of mind all the time. And it's very, very worrying because it's like mobility and arthritis, but your eyesight is just so fundamental if you have it. And I think it just creates a lot of stress. Do you find that uveitis, or is there any data to suggest that it responds to stress, for example? Because you know, there is some evidence that autoimmunity in general responds to stress, among other things, potentially as a trigger. Is that true for uveitis too?
I haven't found that. Just sort of looking at it, I stand open to correction. I don't even know if we've actually looked at that, to be honest with you. We kind of just sort of see it and treat it. Yeah. I mean, there probably is some relation. I mean, if you're saying kind of joints respond to stress, some people with, you know, difference in barometric pressure, it would make sense that the eye, which is also has inflammation, and it would also respond to stress. Yeah,
it probably, I mean, it's all related, it's all immune mediated, and some of the evidence I'm saying is that it's one thought to be one of the triggers, like a virus, for example. It activates the immune system and it triggers a flare. So whether it's inflammation in the knee or inflammation in the eye, I suppose it's driven by the same mechanism, I guess. Anyway, it was really interesting. I'm really glad that you did this. It was really great. Thanks.
Thank you.
So, I mean, that sounds like an interesting area of research to see the relationship of stress with the eyes themselves and the uveitis. Are there any other questions? I have a question, if there aren't. Yes, is it Ines? Welcome on.
Hello, everyone.
Hi, how are you?
Hi. Good. Yeah.
Please tell us
Tired, but
about you and your child, how old they are, their diagnosis, etc.
yeah. Okay. So we have an 11-year-old daughter. She was diagnosed a year ago with, juvenile idiopathic arthritis, and now this year she was diagnosed with the uveitis condition. So currently she's on a low dose steroid that she's weaning off. She first started off with the strongest, I don't know, it's like prednisone or something like that. I can't think of the name now, but she started off with that, and then eventually she is being weaned off, and she's now taking her eye drops every second day. Yeah, every second day. And then the ophthalmologist that we are currently seeing, we're seeing now again in December, and they said, once if the eye is stable, which at the moment it is, and it's actually quite clear, then there's a possibility that she might now get off the eye drops completely. She is on methotrexate at the moment, yeah, and we are waiting for the biologics approval. So one of the questions that I do have is, you mentioned earlier on the fact that it can go into remission and then reappear again. It's not something that can completely go away. My question is now, when it does maybe go into remission and then pops up again a couple of years later, all the continuous treatments, does that have an effect on the long term?
When you say continuous treatment, do you mean with the eye drops, or do you mean with the methotrexate?
Just like the eye drops. Yeah, the eye drops and the eye specifically.
So one of the complications of long-term steroid use can be the likes of cataracts. So it's a known risk factor, but it tends to be your high dose long-term use, and that's why your ophthalmologist is trying to wean her down and get her off them. Okay. Again, glaucoma is another risk factor. Okay, or possible complication. So yeah, it's mainly sort of long-term continuous use. Okay, and as ophthalmologists, we're very aware of that. So we kind of wouldn't keep a kid on. We try not to keep a kid on steroids long term. Okay, there's some kids that need it, and it's kind of, you have to weigh up your risks versus your benefits. Yeah, I hope that answers your question.
Yes, it does. Yeah, thank you.
Pleasure.
Thanks, Ines. So, Dr. Cullen, what I hear you say is that, and Kath mentioned it as well, there's the disease and there are the meds, and there are risks and benefits associated with the meds, which need to be weighed up, and then careful thought also needs to be given to what, so if the child is presenting with some symptoms, some eye issues, that we need to think carefully about, is this the disease, or are these the meds that might be affecting the child? So as a parent, how does one tell the difference? How do we especially as new parents facing these things for the first time, how do we talk to doctors about this? How do we try and assess these things ourselves? What do you suggest?
Laura, are you asking how would you as parents kind of pick up uveitis?
No. So, I mean, that is another question that I would like to ask, because I think that there will be new parents who will watch this as a recording later on. And that is another question that I have is, you said that it's a silent issue. So I would like you to answer how one might understand whether your small child has an eye issue, or so for small kids who can't express themselves, how could you tell that your child has an eye issue? And then older kids, these things creep up on you and you don't actually notice. So that is one question which I'd like you to answer. But what I was interested in understanding is a little bit more about the risks and the benefits associated with the meds and the disease. And as a parent, how do you handle that?
Sure. I think, each case is very individualized, and that's a conversation between the treating ophthalmologist and the parent and the rheumatologist. So I'll give you an example. If a child has got anterior uveitis, so inflammation in the front part of the eye, which often does not respond quite well to steroid drops, but we put this child on steroids and we get a rise in pressure. So now we move into a different area where I've got a complication, but I've still got inflammation in the eye. So ideally, I don't want that child to stay on the drops if there's another form of treatment. And that's when I would sort of ask the rheumatologist, if it was not related to JIA, it was just a simple uveitis, could we start oral steroids or methotrexate to treat it in a different way? If the child's on methotrexate and develops liver issues, then you kind of want to move into a different treatment form, maybe a biologic. That's not my area of expertise. So if there's complications from the treatment you're using, and if there's another form of treatment, it would make sense to move across to that, to try and negate those complications, but still treating the inflammation of the eye.
I know it sounds like a little bit of a silly question, maybe, but especially with when you first have to deal with these things, these are really tough questions to ask, it's difficult to almost express the question, I suppose, when you have a newly diagnosed child, and it's such an emotional trauma to have to deal with. So thank you for answering that. I've got another question from parents as well, and that was to my second question. If you've got a really small child who can't really express themselves, or maybe an older child who's, 8, 9, and who can express themselves, but who might not notice that they have an eye issue, how can you tell? So it's Joelle, who's come onto our chats every now and again. She's asked, there might not be noticeable symptoms, but what can we look out for as parents? That could be a risk or an indication.
Sure. By the time parents are picking it up, it's too late. So you'll notice the cataract. It's too late. If the eye goes hazy, again, you'll notice the complications. And that's where screening is so important, because unless you've got that high magnification slit lamp or slit beam, you're not going to pick it up. And the inflammation is going to go on for years, months, and lead to those complications, which you will pick up. And you don't want to get to that.
Okay, thank you. And are there any behavioral things that, might a child, stop reading suddenly, or they read?
It'll be loss of vision. Yeah, so blurriness, again, that's a complication. Yeah, blurriness, light sensitivity, noticing things or floaters within the eye. But again, that's pretty late, sort of the light sensitivity and stuff. The loss of vision is very late. And your older kids, they get to a stage where they can pick up those things. They can pick up, my vision doesn't feel quite right. I'm seeing what we call scotoma, so a black area. I'm seeing things float about. They begin to recognize it. And they can often present pretty early because they know what to look out for. And it's changes in their vision. It's changes in the quality of their vision.
Okay. So what I hear you say is that once a child has experienced a uveitis flare or some kind of eye issue, when that gets managed and possibly comes back, then the child is then able to recognize it.
A lot of times, yes.
Yeah. Okay. So the child develops a sense of their own body and what feels good, what's right, and what's then wrong. Okay. Any other questions?
I had a closing question if nobody else wants to go. Does anyone else have something to say before I jump in?
I also have a question, but yeah.
Okay, Lara, you good, because mine.
Okay. I would like to know, Dr. Cullen, any tips and tricks. So, you know, eye drops, how
So what do I tell my parents? You can ask the child to lie down and close their eyes. And if you put them in the corners, just between the nose and the eye, and then if they open their eyes both at the same time, sometimes it'll trickle in. You're not guaranteed. Another thing that I have suggested is do it while they're sleeping. Okay, you're guaranteed of getting something in, but again, you might wake the child up. It's sort of pulling down the bottom lash and gently popping it in. And sometimes, you know, you need to get another parent involved, and it just has to get done. Again, you know, you're doing it for the benefit of the child. Kids, you know, young kids don't understand why you're doing it. It's a thing dropping into their eye. They get a fright. You know, sometimes make it a game if you can. You know, mommy's putting the eye drops, let's put the eye drops. You know, Dolly's getting her eye drops. So yeah, those are some of the tips and tricks. If anyone's got any others, you know, I'm open. I'd love to hear them. But those are some of them that we do sort of suggest.
Okay, thank you. Does anybody have any others? You know, what I heard you say earlier is the importance of the relationship that you have with your patients, as well as creating a fun environment. And I suppose as parents, you know, that's also something that can help, is besides the tips and tricks, is creating that loving, safe environment. And then, you know, also bringing a little bit of fun into what's otherwise sometimes a really tough situation. Okay, Kath, you had a question?
Well, I just, to your points, Claire, screening, that's really for me the key takeout here. So you went through the screening quite quickly in your presentation. If I want to send a message to our parent support group, I want to say to them exactly the key takeout is screen, largely asymptomatic. By the time the symptoms appear, it's too late and it's gone too far. Are you able to briefly give us some screening guidelines, or is that little image, is that possible for you to send that to me?
Yeah, absolutely.
Just send that off to the parent support group so that everybody has a good sense of what those screening guidelines are.
Absolutely, can do that with pleasure.
Okay, fantastic. And then we'll just communicate that to all of our parents.
Sure.
Cool. That's it from me. I finally run out of questions. Thank you so much.
Thanks, Kate. So if there aren't any other questions from anyone else, I'll close out. Anyone else? Okay. So
can I ask a question?
Yes, of course.
Just quickly.
Yeah.
Do you ever get, so obviously there's a lot of emotional sort of, there's a big emotional side for parents and kids. Do you ever get sort of the psychologists involved, especially with the younger kids, even the older kids? I would imagine it's quite a bit to deal with. Yeah. Is there a role for psychologists in JIA? Yep. Yeah.
I'm going to jump straight in. It's my absolute passion. I always tell people, if you've got a GP for your body, you need a psychologist for the rest of you. And especially when it comes to a shocking diagnosis like juvenile arthritis in a very young child. Often our children are diagnosed at a very young age, as you'll know. It is not something that we are prepped to handle, that we have any experience of in our families. There was no role models. If we didn't grow up with chronic disease, it comes as a terrible shock, and we have nothing to lean on in terms of learning, and that's an essential part of humans, that we follow from what we've learned. So at Arthritis Kids, we stress the importance of counselors and psychologists. We have focused a lot on understanding the symptoms of an overwhelmed central nervous system, and we've tried to reposition it we've tried very hard to reposition it not as a symptom of not coping, but as a symptom of a central nervous system that is overwhelmed and can no longer absorb and respond to stimuli appropriately, and is needing some assistance to just release some of the stimulus. So I agree with you 100%. It's a key focus at Arthritis Kids. It's something we, well, I certainly potentially, I don't know, everybody knows it's my key thing. It's an essential part of the team as far as I'm concerned, and we've tried to put it into our literature, and it's certainly something that we reinforce to the parents on the group and often, especially with young children, you can address the child's needs just by the parent going for counseling. It doesn't always need to be the child going to see a play therapist. If the parents find better ways to support the child, or more effective, it's not about better, it's more effective ways to respond to what the child is going through. Very often that's all that's needed. Children take their lead emotionally from parents in the household, and if the parents are calm and in control, the child feels that, knows that, recognizes it, and feels safer. And often we can just address it that way, or it can be addressed that way. But it's an excellent point, and I couldn't agree with you more. It's essential.
And a last question for me, is your support group only for JIA? Like, would you be open to like sort of other kids with inflammatory sort of uveitis joining in with an idiopathic diagnosis or not known diagnosis, or is it specifically juvenile arthritis support?
I'd be very open to developing a group for children with uveitis, because they'll have that in common. I might have to give that some thought. We've tried to keep the group very specifically to juvenile arthritis, and the percentage of uveitis is actually quite low. If we added a lot of uveitis patients, it might become more about uveitis, and then we'd lose the opportunity to talk about the joint involvement. But I think if what you're saying is that there is a need for support for parents raising children with uveitis, and it's not necessarily a complication of JIA, I think that's certainly something we can look at.
That would be appreciated.
Yeah, the best way to do that, what I'll do is I'll put it out to the parent group. I'll ask among parents with experience. We've got a couple of parents who've had years of experience really battling uveitis, a couple of really experienced people who've been sort of at this for a while, and I'll just try and see if there's someone there who'd be prepared to lead that, and we'll give the details, and they can potentially start that as an offshoot. Yeah, absolutely, we could look at that.
Thank you.
Yeah, thank you. And what I hear you talk about at the end of the session, what you spoke about earlier as well, Dr. Cullen, is the importance of support. So the support group plus possibly a psychologist or a counselor as a support. And earlier on you spoke about teamwork between yourself, the child's rheumatologist, the parents, and the child. I mean, even the question around tips and tricks takes a lot of teamwork. And that for me was what popped out as you've been talking this past hour, is the importance of a team, as well as you mentioned a sensible approach. So things like not jumping on a trampoline. I think we'd be quite cautious with that anyway as JIA parents, but and that maybe is a question for another time, is what other sensible things should we be thinking about? How do we apply common sense in dealing with our kids? Our time is up, so I'd like to say thank you very much. If there are any other questions, could we pop them to you on email?
Absolutely. More than welcome.
I'll channel them. That would be great. Thank you very much. And your practice is in Sandton, correct?
Correct. Yeah.
Okay, and it's called KidsEyes.
Yeah.
And if we need to get a hold of you, we can just Google KidsEyes and Dr. Claire Cullen. Okay, great. Thank you very much.
Thank you very much for having me, and thank you for everyone for joining.
And I knew we would get to an hour.
Thank you, Laura.
Okay, thank you. Take care.
Have a good night, everyone.
Thanks. Night, everybody. Bye. Thank you, Laura. Thank you.
Bye-bye.
Bye.
Thanks, Kat. Thank you, everybody. And your cats. Thanks to the cats.